Hello, everyone, and welcome to today's TripleTree Thought Leadership session. Before we get started, I'd like to go over a few items to help you get the most out of today's session. You've joined the presentation listening using your computer speaker system by default. If you would prefer to join over the telephone, just select telephone in the audio pane and the dial-in information will be displayed. You'll have the opportunity to submit text questions to today's panelists by typing your questions into the question pane of the control panel. You may send your questions in at any time during the presentation, and we'll address questions throughout today's discussion. I would now like to introduce Michael Carroll.
Good morning, everyone, and welcome to today's Market Insights live session. My name is Michael Carroll, and I'm the Chief Marketing Officer at TripleTree. Today's session is focused on employer-sponsored health benefits and strategies to move to self-funding. We're fortunate to have a great group of panelists this morning. A quick reminder that the views and opinions expressed in today's session are those of our participants and do not necessarily reflect the official policy or position of our firm. To begin today, I'd like to introduce my colleague, Jason Grace. Jason, I'll pass it over to you to start today's conversation.
Good morning, everyone, and thank you so much for being with us on today's Market Insights live session. My name is Jason Grace, and I'm a managing director on our advisory team here at TripleTree, where I lead our transaction activity in the employer-sponsored health and benefits market. We're really looking forward to today's session, and again, thank you for your participation. I also want to introduce my colleague, Brian Thomas.
Hi, good morning, everyone. Thanks for joining us. I'm Brian Thomas. I'm a director with TripleTree. Alongside Jason, I cover the employer benefits sector for the firm. Today, you'll see me popping in and off. I'll be monitoring questions from the field and facilitating the discussion with the panelists. So thanks again, everyone, for joining us.
Great, thanks, Brian. So today's conversation is about this transformation occurring in employer health and benefits. Employers have long struggled with rising healthcare costs, and we see a continued growth in employers choosing to self-fund. Part of that is because there are new solutions that make that feasible, and that's going to be a major theme we cover today. So we're going to have two key areas that we'll cover. One is this expansion in self-funding and why that is, especially as the down market in the small and mid-sized employer groups are moving to self-funding. And second, we're going to spend a lot of time talking about cost containment strategies that employers of all sizes are successfully employing. We'll be taking questions, as Brian mentioned, via the chat, so please feel free to submit those as we go along, and we'll do our best to incorporate them in the discussion. So without further ado, we're thrilled to introduce our diverse set of panelists and leaders of some of this healthcare transformation that is ongoing. Andrew Kavanagh is the CEO and founder of Pareto Health. Pareto manages group captives that allow smaller self-funded employers to reduce the volatility in their healthcare spend by diversifying that risk across the captive's member base. So welcome, Andrew. Kurt Fallbacher is the president and CEO of Advanced Medical Pricing Solutions, or AMPS. AMPS is a healthcare cost containment company that focuses on medical bill review and reference-based reimbursement. Jose Rivero is the CEO of HealthComp, which is the largest independent third-party administrator of self-funded medical programs in the country. And Adam Russo is the CEO and co-founder of the FIA Group. The FIA Group provides healthcare cost containment techniques, offering claims, recovery, plan document, and consulting services designed to control healthcare costs and protect plan assets. So welcome to all of you, and thanks again for being part of today's discussion. So let's dive right in, and really with that initial theme around the move to self-funding. So Andrew, let's start with you. The interest in adopting self-funded strategies is growing rapidly, as I mentioned. It's a critical strategy for employers to really harness and take control of this major line item in their expense line item in their P&L. So I'd love to hear from you about the historical barriers to self-funding, especially in the small and mid-sized market where you have Pareto focus, and how that's evolved to make it more realistic and sustainable for these groups to self-fund.
Sure. Thanks for having me today, Jason. The old adage is that necessity is the mother of all invention. And at $11,000 per employee per year, there's the need for a lot of invention. And so when you think about self-insurance for the small and mid-sized employer, they've been conditioned, and I won't get into sort of who did the conditioning, but they've been conditioned to think of self-insurance as being risky. And so two things have really changed in my mind over the last couple of years, Jason. The first is that there are new products, and not a surprise, I'm a little bit biased towards one of them called captives, but we used a captive to allow that small and mid-sized business to self-insure where they otherwise would not be comfortable, it wouldn't be palatable, it would be deemed too risky. And 70% of our new business comes out of fully insured. And so we absolutely seeing that being a big inflow of employers to the market. But the second thing that I think is important, and maybe more important, is that awareness has changed, is that those small and mid-sized businesses are more aware of what fully insured is and isn't. Again, I think they've been taught for years that fully insured is this great thing, it's stable. And as they dig into it more, I think they realize that there's some flaws in it. They realize that they're going to pay their claims no matter what. And so if they're going to pay their small claims in particular no matter what, then they might as well move to a program that gives them more control, gives them the opportunity to bring cost control to bear and reduce their costs. We talk often about the phrase deferred, not insured, when talking about fully insured. And what I mean by that is that a typical employer pays a premium called $1 million. And then a year later, it adjusts to actual based on what claims they had. And so there isn't this amount of risk transfer that people have always thought there was. And so again, I think the awareness of how fully insured works is one of the key things, in addition to new products like captives, that are pushing a lot of people into self-insurance.
Thanks, Andrew. Kirk, I'll ask you the same question because you tackle these issues from a little different angle. So what are you seeing as new solutions that are allowing groups to self-fund that historically didn't think they could do so?
Sure, thank you, Jason. Sort of building on what Andrew was mentioning, the idea of cost control and transparency, a lot of technology advancements are helping in that area. So what was previously unavailable to the mid to smaller market is now available. For example, if you look at the step down of the number of employees that could get healthcare from their employer, all the way down to those that are actually getting it as a employee, a part of a 50 to 200 employee size group, there's less than 20% of those are self-funded. So there's plenty of opportunity to bring the things that Andrew is talking about into that market. And before you couldn't do it because it really wasn't scalable. So now we're using things like machine learning, data mining techniques to figure out what are the right prices for those self-insured groups or self-funded groups to actually pay for their healthcare coverage.
Great. And Adam, directing a question at you, as you help employers and the administrators with plan design to address these challenges and make these new self-funded arrangements feasible, what have you seen that's making the biggest impact?
The biggest impact is basically, just talking about what Andrew and Kurt mentioned earlier, having access to the tools, but actually educating the employees and their families, the participants, right, the dependents, on how to utilize those tools. So what we have seen is a shift into incentives, empowering employees to actually care about the cost of care and not just what their deductible or what their out-of-pocket is, to actually look at the full cost. But I think one area that still needs a lot of work, but we're starting to see some trending in that direction, is actual access to quality of care. So regardless of what you want to do when it comes to cost, whether it's reference-based pricing, all these other alternatives as it relates to wrap networks, out-of-network claims, the key still is how good is a particular facility. But not even more in depth than that is how good are the actual surgeons within that facility. That's the level of information that now is accessible to employees, their family members. So, and that's right on their app. I mean, the bottom line is the tools that are out there now weren't available 5 years ago. So if you have 50 lives or 100 lives, you now can actually see what those cost comparisons are, how that's going to affect you, how that's going to affect your family, how it's going to affect your overall plan engagement. And I think those things tied in with obviously better plan language when it comes to what you'll actually pay on claims, but really getting employees to become consumers of healthcare and getting companies like the ones that Andrew was talking about, those smaller employers who for years have thought, well, healthcare is, it's an expense, but it's not the same type of expense as all my other expenses. I can control those in some fashion. When it comes to healthcare, I'm just listening to my broker and doing whatever he's telling me to do. If we can get employers to actually look at healthcare expenses no differently than their other expenses and realize that they actually have some control and ability to create change, lower their overall costs. I mean, just last thing I'll bring up on this point is think about what an employer does and requires from their employees when it comes to getting a raise. Okay, to get a 2% raise, they have annual reviews, self-assessments, all these things they have to do, training, testing, etc., in order to get a raise. But that same employee, if they decide to get a $100,000 surgery with a bad facility, with a bad surgeon performing it, with a high infection rate, high readmission rate, that employee has no control over that, but they can. And those are the tools that Andrew and Kurt were talking about. But the key part of that is actually educating the employees and their family members on how to utilize those tools and how it will benefit them and the employer.
Great, thanks, Adam. So a key part of this when someone moves to a self-funded arrangement is you need a TPA to administer that plan. And one of the advantages a TPA brings is unbundling. So when you're in a fully insured arrangement, you're basically just getting whatever your health insurance carrier throws at you as part of their solution. But with a TPA, you can pick and choose which of the different vendors, which of the solutions you're employing. So Jose, I'd love to hear from you from a health comp perspective. How you're helping on the unbundling side and how that plays into the ability to effectively self-fund.
Sure. And a lot of the levers we've been talking about just in this call need an engine, right, to administer all this, right? And previously that engine, that administration capability was not there before. And TPAs come in to be able to implement and deliver everything that we've been talking about. In particular, kind of we concentrate on one side, helping our clients manage their cost. And on the other side, to highlight that a little bit more, we also want to help our members experience, a better experience, right? Get that net promoter score up in a sense. So it's that kind of a dual objective that TPAs are delivering of helping manage cost and at the same time improve the member experience. And the reason we're able to do that is we bring new capabilities that are helping the whole unbundling self-funding market. And that would be things like plan customization. A lot of what Adam was saying before, we're able to obviously implement. Our systems and our business model is geared toward a lot of customization and flexibility. We have full data transparency. TPAs offer that, so it allows everybody to manage their costs better. We've been talking about point solutions. TPAs bring that ability to fully integrate any point solution in the market, and PBMs, integration with benefits platforms. Many of us bring our own benefit platform, so it's kind of an integrated digital experience. And then there's the flexibility on branding, ID cards, and everything else. So it's that combination of all these new capabilities that were not available before. They're not available in an ASO model. That's helping definitely drive the self-funding and unbundling market.
Great. So Adam, you pushed pretty hard on what I just simply call physician quality or provider quality. And we all know there's been cost transparency initiatives for many, many years, and that's been highly visible. But we at TripleTree really have seen very few companies that have been able to figure out the quality piece, both from how you measure quality and then how you disseminate that information to the members. We have seen some select situations where companies are doing that very successfully. But I'd love for all of you, are you guys seeing momentum on the quality side? And without getting into specific company names, do you think that there are scalable, feasible solutions related to physician quality that your clients are deploying to help solve some of those issues that Adam brought up? Adam, why don't I hit you first because you brought up that.
Yeah, we're using them. So that's we're a self-funded plan, and all the things that I've been promoting and talking about even today, all our webinars, et cetera, are all things that we first try on our own employee population. So when you talk about the quality measures, everyone out there has some information related to quality, but typically it's at the facility level, okay? But here's what I know. If I go to a local hospital and there are 4 surgeons that could do my knee replacement surgery, they're not all the same. Some of those doctors, some of those surgeons performed it more often than the others. Some have higher readmission rates, higher infection rates. All that information typically is not being made available, especially in the fully insured and ASO business. That doesn't exist. But that's the type of detail that you can have at your fingertips, right on your phone, to help an employee and their family members make a better decision. But why are they going to do that? Well, you would think most people would say, well, the reason they would look at that information is because it's their own body, right? Like they want the best surgeon with the best quality for their, for their own surgeries. But one of the things that we also try to tell people is incentivizing employees to care about the cost of care is also important. You brought up, Jason, you brought up transparency. It's one of the scariest things for me is transparency, just on cost, not talking about quality. And here's why. I mean, if you show a person 2 different prices for 2 facilities, people will automatically assume the more expensive one is the better place. I mean, that's just how people think. You think that way with the car, with the TV, with anything you buy for your home. My wife definitely thinks that, no question about it. But that's the kind of stuff we're talking about, is showing people you can have the same or better quality of care with details all the way down to the physician level and still save money for the plan, have a better outcome for yourself personally. And that's really what we're trying to educate people on. And I believe it all starts with access to direct primary care. That's another key element, I think, of a plan design, is having access to those type of doctors who actually understand your plan. And when they push you, when they're as a gatekeeper for your benefits and for your health, as they're pushing you to get an MRI or advising you to to see a specialist, they're not just cycling you through their health system where everything might be 10 times more expensive. They're actually looking at freestanding MRI facilities, et cetera. So it comes down to incentives, it comes down to consumerism, but also access to those quality metrics as well as the cost metrics really can make a difference going forward.
Great. So Andrew, I'm going to go back to you on this general topic too, because another theme I've heard you talk about in the past is just buy-in of the employees. So there's one part that Adam's talking about is incentives, but a key advantage that the smaller employers, even to the mid-market employers, have is they have a different culture than in a company that has 10,000 or 50,000 lives. So what are some of the things you've seen in the smaller employers that allow create a culture that gets the employees to buy into some of these healthcare programs?
Yeah, I think it's a great question, Jason, and that we look at our business, which is in general made up of lots of, call it 100 to 150 employee companies. And let's just pretend we have 1,000 of them. And if you look sort of over the back of my shoulder, there's a company there called Comcast that has about the same number of employees. And so I often compare and contrast us to them because in aggregate, we have the same number of employees. What's different to your question is that our employers are small groups of 100, 150 employees where there is a culture, where there is a buy-in. And so that message that they're trying to get across is so much easier when the person that manages those 150 people is the owner of the company and not a mid-level manager at a Fortune 500 firm. And so I do think that there are some challenges to that because things aren't necessarily as scalable because they're broken up into these different companies. But the messaging and the buy-in and the culture and the passion for what the employer is trying to do is much easier to share in an environment like that than it would be in the equivalent size Fortune 500 company.
And Kirk, going to you, the culture, the communication to the employees and their families when an employer shifts from a traditional health plan to one that has reference-based reimbursement tied to it is really key to success. So I'd love to hear from you how your model, what kind of buy-in is required and how employers are making sure the employees understand the shift that's happening and the reason for it.
Yeah, it picks up on the same theme of consumerism. And if you look at the growth in healthcare costs, much of that has been shouldered, the new growth, by the employees. So if you take an average salaried person across the US, almost 37% of their take-home pay is going to pay for healthcare. So the pendulum shifts every year. It talks about quality it talks about cost. It can't shift further more to cost because we can't put more cost burden onto the employees. So the buy-in that Andrew talks about is this idea that you will be getting more take home in your paycheck if you start to act like a consumer. Healthcare is tough. It's opaque. It's complicated. There's a lot going on, and we've been trained not to ask the price. And the concept of being self-funded is you are responsible for not just your spend, but the spend around you, all the other peers, all your colleagues in the company. And in a smaller environment, a smaller employer, you can see the impact. You get to keep a longtime colleague. You maybe get to have bonuses that get distributed out. So that buy-in can actually be felt in the pocketbook, which is one of the main things that we see, that there's several very good quality providers. Overall, people that go into the healthcare system are noble. They want to solve problems for people to make them healthy. They're not there to try to, take money away from them. But there's just a lot of layers of obfuscation in the system. If you can pull those out, what happens is the actual employee and the members of their family get the benefit. And if you look at those employers as a family, then it spreads and it makes everybody sort of healthy. So that buy-in is key. Continual education is another key factor because it is very different than a traditional plan where you go anywhere and you don't ask the price and somebody later on pays it. You don't know what the contract was, how they paid it, where the money even came from. You just know that you paid your premium and you had your copay. In this model, you sort of take some ownership and you're a part of the process itself.
Great. Well, I see Brian joined. So Brian, is there a question?
Yeah, maybe one question from the field. And Adam, you just sort of brought up the topic of direct primary care and this being a key strategy for employers. The question is around in this new environment as we move, certain employers will move more remote. How are groups thinking about direct primary care and in particular shifting to sort of virtual type strategies as it relates to DPCs in your discussions with employers? And Andrew, you may have perspectives on this topic as well.
Well, there's no question that we saw growth already in the past year as it relates to telehealth, as well as direct primary care, direct contracting with facilities, specialists, et cetera. But with COVID, it's mandatory. That's what we have seen over the past 6 months is more and more people utilizing telemedicine, more and more people doing virtual calls with their doctors. And as they do that for the first time, as all of us have done that for the first time, people sort of get used to it, sort of understand it, sort of like it. This might make sense in many circumstances. So the ability to do that is key. But here's the problem. What we're seeing on the claim side is many of these same facilities are charging the same price, whether it's an in-person visit or it's a televisit. That's one thing that still hasn't been figured out yet that we're not fully seeing. But I can tell you that 30% of the plan documents that we write when we first get them still don't allow telemedicine. So even though now it's basically a requirement for everyone to do it, there's still a third of plans that aren't doing it correctly. But I want to add one more piece to what Kurt just mentioned, and that is the education. We look at it as, think about how people typically do enrollment for the health benefits. It's like, here's how you sign up, here's how you sign up your family, choose your network, choose your deductible, and that's it. We look at it differently. We look at mandatory actual workshops, where it's no different than how you train someone for their job. You train them on healthcare expenses. You explain to them where the risks are, where the cost drivers are. And it's part of the normal company functions. That's what that's what we're seeing. We're seeing more and more employers do it. But as you mentioned, remote and people in rural areas, right? One of the biggest, holdbacks in regards to direct primary care is there's just not enough of them across the country. I've been wanting to do direct primary care here in Eastern Massachusetts for years. We couldn't do it until about 2 years ago when there was actually a facility, a doctor who had an office willing to get paid on a per employee per month basis. So there's a lot of people that want to do these things, but just volume wise, there's not enough people out there willing to do it.
Thanks, Adam.
Andrew, you want to chime in on that? Because I know Pareto's been involved in DPC for years.
Yeah, I think my comments will all parallel what Adam said. But going back to sort of one of the questions that Brian asked is how has COVID changed this? And I sort of distinguish between what I think of as telemedicine, and my semantics might be completely wrong, but I distinguish a bit between what I think of as telemedicine, which is calling the doctor that you've never met before to get a sinus infection or an earache solved, and then virtual care. And virtual care is your doctors, your providers, and you are seeing them via technology as opposed to in person. And so we've seen an increase in both of those things throughout COVID. And I think the one that interests us the most is ultimately the virtual care, where so much of a doctor visit could happen virtually. It could happen before you walked in the door. If you think about, the 100 units of time you spend in your primary care doctor's office, how much is allocated to the actual care? It's a small fraction. And so I do think that more and more of this is going to happen online before you get there, shortening the window that you have to be there, and even eliminating the window for many things. And so a lot of things will become what we think was confirmatory as opposed to exploratory. And I think that's going to be great. And to Adam's point, it's absolutely going to help people that are in remote areas, because you might take a DPC practice that's in a big city and they can actually care for people that are now 50 and 100 miles away who don't need to come in very often. And so we do think, again, that COVID has created that change, and that change will be permanent and positive.
So Jose, maybe you could bring all this together for us, because you as a TPA, you need to bring all these solutions together for your clients. So how is this working in reality? And when you have a new group that comes on, either from a fully insured group or from a legacy ASO or TPA solution that maybe can't integrate all these solutions together, what is that member experience? How is that member experience different than it may have been in the past?
Yeah, and I think that's where the digital platforms, a little bit that I referenced earlier, come into play. So definitely to put all this together, it's very complicated, right? Many different providers, point solutions, and to really make the member experience better, you need to go to one place only, with single sign-ons to everything, where you see your clear picture, you understand what your options are, you look into cost, quality, all the things we've been talking about, and really are able to manage your benefits, your more complicated benefits, in an easier way. So it's kind of that digital platform, to call it, that brings it all together. And you need to have the capability to really interface with all these point solutions for it to work. Related to that and to our prior discussion, one metric we track in some of our services, employee engagement. So, but we were saying, right, people need to be educated and engaged. And we actually track that. That's critical, right? To see, are people taking advantage of the services that are offered to them? Is the number going up or down? Why is it going up or down? So it's getting to the point where we all believe this is so important that it's actually getting a metric. And we track a percentage employee engagement with some of our services, and we'll continue to expand that. So it's kind of this notion of education, like Adam was saying. We participated in a lot of open enrollment sessions. Now, obviously, a little bit more by phone and video, but we help the companies, right, understand what they're dealing with. There are refreshers along the way. In the case of RBP, there are a few more refreshers, right, since they need a little bit more education. Then you have the whole digital platform. They're constantly being hit with messages and clarifications and reminders and new tools. So it's that communication, engagement, reminding them of what's happening that makes it all happen at the end.
Great. So let's transition. Sorry, go ahead, Adam.
I'll say the problem that we're going to continue to see, though, which ties into what Jose just said, is, a majority of people, employers and their families, still think of their out-of-pocket and deductible as the only thing that they actually care about. So regardless of all the tools that we have and the programs that we put in place, until that changes, we have at least 20 hospitals here in the Boston area, okay? The copay and deductible for every one of our employees is exactly the same, regardless of what hospital they go to, because it's all within a network. They're going places based on where their mother went, or where their aunt works, or a friend told them to go there. I mean, more time is spent choosing the television in their living room from a quality perspective than where they're going to have a delivery of their baby. I mean, that's just the reality. I mean, how my wife chose the pediatrician for our kids was all the other moms at our school, that's where they go. I mean, the guy could be horrible. She has no idea, but she knows the quality of the big screen TV. the quality of the living room couch. That's really needs to change. Until people understand that the cost of delivering a child in Eastern Massachusetts in the Boston area ranges from $8,000 to $60,000 for the same baby. Until people realize that, but their copay is going to still be $250 in either situation. That's where we need to get the quality and cost transparency right into those employees' hands. I don't think it's done enough. I think people this year, especially in the COVID year, are seeing, oh wow, self-funding is great this year. Yeah, because claims are down, volume of claims is down, but depression's up. Prescription drug usage is way up. The number of scripts skyrocketed since March. Alcohol use, fly high. People need to look at next year and go, okay, what are we going to do about the prescription drug costs, utilization, the volume? What are we going to do about the fact that 40% of people have delayed or not getting care because they're afraid to go to a hospital? People are more afraid to go to a doctor's office for a treatment than they are to go to CVS to get their prescription. And that's really what scares me. And for 2021 is, how do we look at these issues that we're definitely are trending, and what solutions can we bring to the table to resolve them?
Great. Is that anyone? Adam threw out a pretty big topic there. Anyone want to try to answer that?
All right.
All right. Well, we'll keep thinking of the answer, because I know. I mean, that was a tough one. There's really no clear answer. It's all about what we've been discussing: engagement, making sure we have the right programs in place as an employer, so that someone with substance abuse has somewhere to turn and they know about that it exists. They know how to access it, because a lot of these employers already have these solutions in place. But as you've all been mentioning, if you have it in place but no one uses it, it doesn't do any good. So, one of the themes we've discussed here is physician quality, is direct primary care, but there's a lot of different strategies evolving on how employers and their health plans and working with their brokers are thinking about provider networks. And historically, there were broad networks that included a lot of people, and there's been a large growth in narrow networks. We have ACO arrangements where health systems themselves are trying to say, we'll give you a better price, employer, if you make sure that your employees come to us and not to our competitive health system. We have centers of excellence models, and I remember many years ago, people were doing travel medicine. I think that still exists, where an employer will actually pay for one of their employees or dependents to fly to the Cleveland Clinic or to a center of excellence, because not only are they going to get the high quality care, but they've potentially negotiated a rate that in the overall cost of care makes sense for the employer to pay for a vacation in some cases for the employee. So there are a lot of these evolving strategies, and certainly one of the biggest areas of growth around these strategies is reference-based reimbursement. And so we have Kirk, as an expert in this field, I'd love to hear from you about, given the growth in reference-based reimbursement, what are the real factors that have increased this adoption in the market, and how are HR leaders, benefits leaders within the companies you're working with, what are they considering when they're trying to evaluate? Should we make the move to a reference-based model versus a more traditional PPO contracted model?
Sure, it plays on that same theme of consumerism. As consumers, we want to price compare, we want to shop. And if the current system doesn't let me do that, naturally just the market forces are going to move us to that pattern. Now, what's interesting is we saw reference-based pricing come out several years ago, and we called it kind of naked RBR. That's where we'd go through, we'd figure out how to price it, and then we'd react. And then we got to the second phase where we had reference-based pricing with some direct contracts alongside of it, like safe harbors. And I really see the future towards this path where you have provider-sponsored reference-based pricing. But I'm going to say it a different way. It's provider-sponsored reimbursement terms that are agreed upon with the employer and their pricer. So there really isn't that middleman concept. When you add a middleman in, there's always extra fluff and extra thumbs in the pie. If you pull those out, you can start to take that savings and share it between the provider to get better newer equipment, or to the employer to have cost avoidance and savings. So we've seen reference-based pricing now going from the early adopter phase to what we'd qualify as crossing the chasm to the early majority phase. Earlier on, 7 years ago, let's say, we had smaller employers. They were pretty much confined within different geographies and different industry codes that had thin margins. But now we're seeing that the 50 dealer auto ship can get the same savings as a large manufacturer. So the large manufacturer is saying, well, if the 50 person company that sells cars can get that 20 to 30% savings, I have 3,000, 5,000 employees. I should be able to get the same savings too. I have buying power. So we're seeing this concept of reference-based pricing crossing the chasm to larger groups with more complicated needs, with different insurance capabilities, different direct primary care reps, their own contracts, and all of that is then based on this idea that more providers are accepting pricing transparency. This obfuscation sort of goes away if we can agree on the reimbursement levels. Now, there's still a few providers that like the fee-for-service schedule, that like the idea of just continuing to add more line items in. They're trying to make the transition to a value-based model or become an accountable care organization, and they're right in the middle. You know, they're having a revenue squeeze, let's say right now from COVID, and they're trying to figure out how do we make up revenue. Well, the last thing we want to do is drop line items off. So how do we get more line items onto the order? So reference-based pricing then makes us as a shopper. It says, I know what this is going to cost. I know what the line item is going to be. I know the quality perspective. I can see how many people have used it in the past. And this provider is not only a good quality provider, but a cost-conscious provider. So as we shifted from those earlier adopters to maybe the early majority, along with that comes more credentials into the market and more health systems that say, yeah, I guess I'm okay with this model. I'll start accepting it and let's see what happens. When we first start up a group in a new market or we enter a new market, you know, we watch for the first 6 months to 9 months to see how the providers are going to respond. We track all of that inside of our data warehouse, and then we put our tools like our provider finder, our pricing tool, our advocacy tools on top of that, so we know where the friendly providers are at in a given market. And then we have care navigators that help steer employees and help them schedule events with those friendlier providers. That's all reinforced by what Adam said with plan design. It's all reinforced by what Jose talked about with respect to constantly reaching out to the member for their member experience to make sure it's working. So all of a sudden you go from this, I've been paying 30% more than I needed to, I'm now a year later and we're still getting healthcare coverage, we're getting our encounters taken care of, and I've got 20 to 30% net back in my pocket. And as an employer, I can bonus that out, I can buy new factories, I can hold on to it for growth strategies. Before, I could not do this at all. So we really see reference-based pricing becoming a viable alternative, but not as that naked RBR, as sort of reference-based pricing as a way to establish pricing transparency. And that's kind of the basis for consumerism.
Yep, that makes sense. So Jose, you work with companies and administer plans that do both the types of RBR arrangements that Kirk's talking about and traditional PPOs. So I'd love to hear from you about, you know, what types of employers or what attributes of employers are drawn, or that it works one for the other versus the other works better for, and some of the things that you've learned along the way for, you know, success in some of these newer models.
Sure. So a lot of the trends that Kirk mentioned are right on, right? We clearly see those in the market. So let me start with the RBP group. And like Kirk said, right, years ago, it was the smaller group, low margin business. And then the main primary driver was the cost savings. That was the decision was heavily based. And again, going back 5-7 years, the decision was heavily based on, am I going to get those 30-40% savings over what I'm currently paying? And there was skepticism around that, and you gave it a shot, all in the hope of getting the savings. All that has evolved to today where it's larger companies, not necessarily lower margin businesses. Like Kirk said, is becoming more mainstream. And the decision making has also changed. So now the cost savings are like a given. Yep, I know you got enough case studies here. I got this. This is proven. I'm going to get the cost savings. So talk to me about the member experience. And that's the big, trend or discussion point we see in reference-based pricing today is cost a given. Let's talk about the member experience, right? Any disruption? What are you guys doing about it, etc. And so that's been on my mind, the big shift from, the type of clients. And there are clients going RBP, they're getting big, right? 4, 5, 6,000 employee lives have gone RBP this year, many of those. So it's the trend is going, but the decision making is, the criteria is also changing. To your point of what's successful on reference-based pricing, for us, it's a lot of education. Right, so we go out of our way on the open enrollment area to educate everybody. Everybody forgets about it, right? So you just got to be the constant reminders, text outreach. Hey, you're in the period where you may be getting a balance bill. Let me tell you how that's going to work. So one key thing that we just can't stress enough is the level of education, reminding them how to handle, a situation once you get your first bill, and that does a lot of good. Right, we just can't be in the back waiting for the phone call. It's this proactive outreach that makes all the difference in the world, and it really helps the experience. That's on one side. On the other side, now there are more tools where you have visibility on the claim. Where's my claim? What's happening? So also the transparency, right, at the claim level. It's also quite important in making RBP work. So it's these key trends, but without a doubt, there's growth, a lot of growth in the RBP space. The other thing we're seeing a little bit more now than earlier is people want to go dual option, we call it, where they want to have an RBP plan as well as a PPO plan and offer both. And we have a number of large clients that try the dual option first and end up going RBP in these cases, right? So they just want to get comfortable with it. So this notion of the dual option is becoming but more popular in RFPs.
And I assume that's exactly, going back to Kirk's point about consumerism. The employer is giving the employee the choice. You can pay more for a traditional PPO plan, or you can pay less and go to an RBP plan. And if you're going to do that, we want to make sure you're engaged and know what that is, so that there isn't this friction that has historically been, the reputation of a naked RVR program.
And if you think about it, the funny thing is, Jose brought up the point of having different options available. The price differential to the employee is significant. I mean, this isn't some small 10% difference. In addition, the type of people that initially will enroll on RBP are typically healthier people who say, I don't need that expense. I don't go to the doctor that often. So you'll see the healthier people, the younger folks typically will join that RBP plan. And folks that will say, you know what, I see my doctor all the time. What if I can't see my actual doctor because of this program? And they might be afraid to utilize it. But I think what Kurt talked about, the history of RBP, it was amazingly well said. I could tell you that that's the problem with it, is that there are still so many employers that think of reference-based pricing that old way. All the noise, only caring about the bottom line, not thinking about as Jose mentioned, that employee experience. And that's where the biggest strides have happened, I think, in reference-based pricing, is changing that employee experience is the focal point, because the cost savings are obviously there.
And Kirk, maybe to you, one question from the field. You talked about the health navigators, you talked about the member experience here. And we've talked about quality a lot in this conversation. Are there ways you're incorporating quality into your solution to help it make it much more of an impact from a cost effectiveness standpoint? And is there still more to do there from an adoption standpoint?
Yeah, quality is an interesting conundrum, actually, because most of the quality metrics are around running a hospital or a physician's office. If you look at like HEDIS metrics as an example, and many of those metrics were derived so that the providers could receive funding back when we rolled out the meaningful use statutes. That's when you had to have a certified EMR platform that digitized healthcare records. And there was a whole bunch of stuff around that to make sure that you continue to use that platform in a meaningful way. Well, when you look at quality, there's a whole bunch of different indicators like those HEDIS metrics. There's some interesting work being done regarding when insurance companies have to write additional checks for procedures that went south. So some feel that's the best way of determining if a provider knows how to do that surgery, is how many people not only come back in for readmission or infections, but how many times does the insurance company actually have to step in and start to fund the follow-on surgery. So I think we're going to see a whole series of new quality metrics coming around, not just things like how the process works from CMS guidelines, but also the financial aspects are going to come into play. Today, for example, we have really smart algorithms for population health. There's some stuff that Johns Hopkins has done and Millman's done to score patients, looking at previous claims for those that are going to have maybe chronic conditions and be more costly for you. Those same sort of algorithms are going to be applied towards the quality of providers and the outcomes that happen. And those metrics will take into account both guidelines and caregiving as well as financial perspective to it. So, Brian, we're not quite there yet. From our company's perspective, we implement many of those quality metrics. You can look at general practitioners or their specialty and see how they rate. But as an industry, we have quite a bit of work to do there.
Great. So this has been fantastic, and we unfortunately only have about 10 minutes left. So let's just open it up a little bit related to cost containment strategies. We've talked about provider network strategies, but Andrew, maybe I'll start with you. What other cost containment solutions are you guys employing that you're getting a real bang for the buck from? And tell us why that is.
Sure. I would look at our clients as pulling levers in three big areas, which would be RX, site of care / care coordination, which we really in many ways just talked about, and then alternative payment methods, which in some ways we talked about. So I'll jump up to the top and start with RX. It's 25% of an employer's spend, rising faster than any other part of the health plan. More drugs coming on the market, more drugs being approved for additional uses. And so it's this thing that is just exploding in terms of cost. And whether you consider it a drug or not, you've also got things like gene therapy that are coming down the pipe, which have huge dollars associated with them and huge benefits too. So that is the area I think that people are seeing the biggest need and also the biggest bang for the buck. And so our clients, with our help, are unpacking the PBM and saying, okay, the person who is determining what drug should be on formulary shouldn't be the PBM who might be getting a share of the rebates. The person who's looking to see if a specialty drug or a gene therapy is warranted shouldn't be the PBM. And so it's taking this thing that used to be sort of fully built, all one, buy it all, and not see a lot of it, what's underneath it. It's being taken apart and put back together in a more efficient and more transparent way. And then obviously parallels everything we've talked about on the medical side. So I would say that's one of the big things that we see. On the site of care, we've touched on it, a huge variation in cost and quality. And so there are different ways to look at it. That could be a center of excellence for oncology. Oncology is a huge driver of large claims. And so where you go for that. I think enhanced primary care, DPC, clinics, whatever you want to call it, is also key in determining where something happens based on price and quality. And then the other things that we see a lot of, which again have been touched on, are RBP and direct contracts, bundling for things like knees and hips. So those are sort of the three big buckets for us. But then I'd also put a couple of themes on top of them if I can do it quickly. The first is that employers are moving from what I think of as passive to active. They're moving from just sitting there and hoping it works to saying, look, I've got to be involved in this. And so it's looking at their data and doing something proactive. We use a formula internally, which is data plus analysis plus action equates to value. And employers are getting that they have to do something. They can't just get data and do nothing. And then the last thing, and then I'll shut up, is that while all this is possible, I think employers, particularly our type of client, is drowning in choice. It's the paradox of choice, where there's so many people that are doing this. And so you need somebody, a good consultant, a captive manager, a TPA, all these different entities have to sort of simplify some of this to make it consumable for that small and mid-sized employer. So long-winded answer, Jason, but that's what we see on the cost containment side.
Great. So maybe I'll just go around to all the rest of you and ask the same question about cost containment. Maybe we'll go Kirk, Jose, and then Adam to round us out.
What 1,000% with Andrew on the RX spend. RX has been just crippling in its growth. And if you look at treatment, you can get the effectiveness of a drug delivered in multiple vehicles, like think like a salve, an ointment, and so forth. But the price differential of just the efficacy of the different medium has to be taken into account. So there's plenty of spread pricing. There's plenty of fluff built into the RX side. So we're looking at this concept of, if we're doing reference-based pricing on the medical side, you can also do the same concept, reference-based pricing on the RX side.
Great, Jose, next.
Yeah, just a couple of thoughts. So within the RX, specialty RX specifically, right, within the RX category, it's a specialty piece that's obviously high growth area. We work with different point solutions, et cetera, but I think the industry is still needing a better answer on specialty RX. That's one thing. The other thing I'll mention is a tool that's very effective to help manage costs is large case management, we call it. That's when you have a nurse reach out to the member, engage with the member, frequently talk, guide them through the process. And the return on that, and having a clinician work with the nurse, with a member going through a chronic condition, that, as simple as it sounds, right, it's a very effective cost management tool, guiding them through the care, reminding them to take medication, helping them with this and that. So I just want to highlight the importance we see in case management and to help manage costs.
Great. Adam, same question to you.
You know, when I look at this, and this is a very big issue for our company and for our clients, is that, think about it, most doctors, when they prescribe a drug to their patient, they have no idea what that cost is. They don't know what that patient's copay or deductible is when they're making that recommendation. So in my opinion, and if you talk to employers and administrators, they'll tell you, oh yeah, we must have some type of great audit program in place when it comes to our pharmaceutical spend, because the PBM is watching. And I think Andrew alluded to, you know, they're not doing what needs to be done. And there's proof in that. I mean, the bottom line is, what we tell our clients is, look at your pharmacy spend on a monthly basis, and then simply look at what can be done. Get that member engagement at that level. Don't just focus on your administrator or your PBM at the end of the year on a quarterly basis to tell you, oh, you could have saved money here, or this is an alternative. To me, there are actual saving strategies right at the member engagement level, literally after the first time or before the first time a particular patient gets prescribed a drug. Specialty substitutes, alternate brand to brand, exact generic, alternate forms of the same exact drug. I mean, these things, all you'd have to do is literally have the ability to text your employee or their dependents, go, hey, you prescribed this drug. This drug has a copayment of this. The cost is X to the plan. Are you aware that there is also available to you this drug, and this drug, even a cheaper generic potentially? And it doesn't make you use it. All it says is, no different than the commercials, ask your doctor or pharmacist if this can work for you. And we've seen that engagement. And when they go back to their doctor, the doctor will say, yeah, but you told me you wanted a gel, not a cream. Well, if the cream's free, I'll take the cream. I mean, these are the kinds of things. I mean, just on our little plan, and we're not some huge company, but in our little company alone, just this year, we saved $28,000 just on that alone. A text that goes to our employees and says, hey, are you aware that you could have done this? A good example of that is, we did a campaign on albuterol, where we actually encourage our membership to make a switch from brand name like ProAir and Ventolin to the generic. And what we've seen is, I think we had 12 people just in our own business make that switch. But for that outreach to those members, with that education, with that communication, with these workshops, they wouldn't make the switch, because why would they? They wouldn't know any better. Because just like my mother says, if the doctor tells you to do X, you're doing it. No one's going to question their doctor. No one's going to question their physician. That's just the way that's just the way it is. So I think getting people to actually ask questions about alternatives, they're going to save them money, put more money in their pocket, as Kurt alluded to earlier, I think is key. And I think that really needs to be a focal point for our industry in the coming years.
Excellent. Well, I think this has been a great discussion. It'd be fun to continue it. Maybe we'll have have a second episode someday down the line. So thank you all. We appreciate for our audience, for everyone participating in today's Market Insights Live session. A podcast of today's session will be available on our website, so feel free to check that out. And I just again want to thank Jose Rivero from HealthComp, Adam Russo from the Thea Group, Andrew Kavanaugh from Pareto Health, and Kirk Fallbacher from AMPS for being part of today's session. With that, we'll turn it back over to Michael Carroll.
Thanks, Jason. So that concludes today's Market Insights Live session. Our next session is scheduled 2 weeks from now on Tuesday, October 6th at 10 a.m. Central. It's titled Behavioral Health. It's here, there, and everywhere. I hope you can join us. For more information about all of the Market Insights Live sessions, visit our website at triple-tree.com/Market Insights Live. On behalf of everybody at TripleTree, thanks again to our panelists. Thanks again to Jason and Brian. Have a great day, and we'll see you in a few weeks. Thanks.
Yeah.